Hi there, and welcome back to Good Distinctions. I'm your host, Will Wright, and Good Distinctions are the spice of life. I'm honored to be joined today by Dr. John DiCamillo from the National Catholic Bioethics Center. John, welcome.
Thank you. It's a pleasure to be here, Will.
It's wonderful to have you. So first, I'll just have you introduce yourself and let our audience know who you are and what you do.
Sure. My name is Dr. John DiCamillo, and I am the Personal Consultations Director and an ethicist at the National Catholic Bioethics Center, which means that essentially I'm in charge of managing our 24/7 free consultation service for individuals. We get calls and emails from Catholics around the country and sometimes even around the world, about 100 a month or more, on any topic in Catholic bioethics, basically from beginning of life issues to anywhere in medical diagnoses and proportionality of treatment all the way up through end of life questions. And so
That's a really neat service. So before we even get into the topic that I'd like to discuss today, how do people access that?
great question.
Yeah.
Just through our website, www.ncbcenter.org. There's actually a place where you can go to personal consultations, and then there's a submission form to submit your consultation request. You can also just call our phone number, which is 215-877-2660, and then just press the button for a consultation.
That's awesome. That's such a great service because there's no shortage of questions. I worked in a parish for 7 years, and I'm working as a high school history and religion teacher now. And whether it's folks in their 70s and 80s who are asking questions, or in the middle of life, or as you say, teenagers, everyone in between, everybody's got
Yes.
questions about very, very important things that affect us significantly, both body and soul. And one of those topics, the reason that I asked you on today was to talk about end of life issues in particular. And so the structure of this conversation will be very simple. And of course, feel free to take it wherever you like, wherever the Spirit leads. But we'll be talking about euthanasia and physician-assisted suicide first. And then more specifically, more practically, perhaps, how do we navigate those thorny end-of-life issues? What sort of decisions can be made medically on a broad scale? So ordinary versus extraordinary means of care. What sort of things should be in a living will or in a last will and testament? Like what sort of practical wisdom can we offer folks today? So if you're listening and that's of interest to you, please follow us along for this ride. But John, I'll have you start. How would you define euthanasia, and what is the problem with it? I know that's very broad, but I guess we'll start there. Because the reason I asked the question that way is there's a lot of things being put out in the media, especially in the news, where they'll use euphemisms. I mean, euthanasia even itself is a euphemism, but there's euthanasia, physician-assisted suicide, death with dignity. I mean, you go down the list, there's all these different names. They all seem the same to me, though, but I'm not an ethicist. I'm not in the medical field, so take it away. What's going on?
Sure. Well, euthanasia, the church actually provided a definition of euthanasia in 1980 in the Declaration on Euthanasia. In fact, I'm not going to cite the definition precisely, but the simple summary is that euthanasia is the deliberate taking of human life, deliberately killing someone as a means of eliminating suffering. Small story short. So either by commission or by omission. So you're either deliberately doing something like a lethal injection, an overdose, whatever it is, to actually kill a patient as a way of leading them out of their misery, or you're denying them something or withdrawing or withholding something which could save their life or maybe is actually essential to them in some way. And again, your purpose is to end their life as a way of putting them out of their misery. That's what it's in.
Got it. No, that makes sense. So when people hear that, people who are not Catholic or who are living in the current societal milieu, like the average folks who don't think deeply about philosophy, that seems like a no-brainer. That seems like something that we should be doing. where, of course, if this person's suffering, we want to end suffering because suffering is the worst possible thing, right? And I've heard people say this, so I'm not trying to make a straw man, but there's a lot of
Sure.
people who really see suffering as the worst possible thing. So what's the Catholic response to that? I mean, how do we what's the
Yeah.
first thing that you would consult in a personal consultation? What would you say to someone who maybe asked the question, I'm suffering a lot, I'm near the end of my life anyway, what's wrong with just letting go?
Yeah. So I would say that since your podcast is good distinctions here, distinctions are critical. And the first distinctions I would make are around, the ending of suffering, or trying to treat or address the suffering, versus trying to eliminate the person.
Okay.
And that is a critical distinction for Catholic moral theology and in philosophy in general, is the idea that, there is something bad about suffering. Suffering is an evil that was brought into the world. In Catholic moral theology, we know, and theology broadly speaking, that suffering did not exist. Death did not exist in God's original design as a result of original sin. So we all accept that suffering is a bad thing. And so we all understand that if we can, and to the extent that we're able to reduce, mitigate, eliminate suffering, great. However, we can't do it by means of killing a person deliberately. So we can't use the fact that suffering is bad as an excuse to say, well, now we're going to kill you in order to eliminate suffering. We can find ways to palliate. We can use medicines. We can try to treat the underlying problem, if that then would hopefully eliminate the suffering associated with it. If we can't eliminate that problem that's underlying, again, we can use analgesics of various sorts to try to reduce that pain, sedatives if necessary, if it becomes extreme. So there are all sorts of ways. And I would add that also it becomes important to consider the existential side of this and the spiritual side of this, because suffering is broader than just pain. So many times there can be a suffering that comes from familial situations, spiritual situations, concern. As we approach death, we are faced with a number of temptations around despair and giving up and these sorts of things. And so it can also be the case that our overall suffering and even the ability to grapple with that suffering can be partially addressed not just by analgesics, but also by addressing our spiritual needs and our emotional needs, psychological, mental health assistance. These things can actually help us, if not eliminate suffering, certainly to be able to handle the suffering, also by giving it a different shade of meaning. And this is something that is a very human dimension as well. So anyway, the short answer would be, I first start with the distinction. Yes, hey, I understand the suffering is real. And yes, the suffering is bad. However, God has created us in his image and likeness. We're good. Our lives are not our own to handle. We don't just get to decide when we die off that whenever we wish. And God has clearly taught us that we don't have the right to take anyone's life deliberately, including our own life deliberately, even if it is a really tough situation, painful, etc. So treat the suffering, don't eliminate the sufferer, to use the words Joe Falter.
Well, and John Paul II does speak extensively on this in the Evangelium Vitae, the Gospel of Life. So if anyone listening wants to get a full treatment of life issues in general, I'd definitely point them in that direction.
Yes,
it's a
and
beautiful
document. It also has a great document called Salvifici Doloris on the salvific meaning of suffering. So that addresses that similar theme more head on in terms of how we respond to suffering.
As Catholics, I mean, we really have we hit the jackpot when it comes to how do we deal with suffering properly, right? I mean, it's I look at all these other religions, and in my history class, we talk about it quite a bit, about the problem of suffering, the problem of pain. And like Buddhism, for example, says life is suffering, right? It takes a very strong stance on that. And so the way of achieving nirvana, of achieving otherness, is by sort of becoming outside of yourself, emptying yourself of everything to sort of not have the pain and suffering affect you. And really that's not what you're saying. That's not what the church is saying. The church is saying, no, suffering is part of life. It's part of this fallen world that we live in. Well, what do you do with it? And that's where that old Catholic adage, offer it up, comes in, that we actually can unite our suffering to Christ on the cross, and it becomes redemptive, both for ourselves and for the world. And so there's a great amount of prayer and grace that can come from these moments, even as difficult as they are.
Yes.
But yeah,
Absolutely.
we can't kill an innocent human person. It's just it's one of those foundational principles. And so then someone at the end of their life might say, "Well, I'm not that innocent." And so your response was, "Well, you still don't get to kill yourself.
Right.
We're not going to let you do this. It's your life has value, even in the midst of the suffering. There's dignity and there's worth."
Absolutely.
And this is not some sort of far-flung issue. We were talking before we hit record that there's every state, at least, has had some sort of ballot initiative or legislation proposed to make euthanasia legal. At the moment,
Assisted
euthanasia is
suicide,
illegal,
technically.
or assisted suicide.
Yeah.
What's the difference there? I mean, euthanasia is
Yeah.
the broader term to end the life of a suffering person.
That's right. That's right.
So what is assisted suicide then?
So yeah, the distinction is really just in terms of who carries out the action. In other
Okay.
words, if the euthanasia is any, deliberate taking of a human life to end suffering. Assisted suicide would be when it's not someone else who's doing it. Let's say like the doctor who's taking my life, or a family member who's, deciding to remove the ventilator, etc. It is actually me. I'm the patient, and I say, I'm going to end my own life, and I need help doing it. I want to be put out of my misery, and so I'm going to ask the doctor to give me drugs, to write a prescription for me, for example, that then I'm going to actually ingest on my. I'm going to take that final action into my own hands. So the distinction is really just in terms of who the agent is that carries out the action. And if it's me as the patient who actually carries out the action of ending my life, then it's assisted suicide. And I needed assistance from the medical healthcare professional. Whereas if it's euthanasia, we would generally use that term when it's somebody else doing it, like the healthcare team or a relative or whomever who's going to apply this to me or withdraw this from me.
Got it. Because at present, euthanasia is illegal in all 50 states.
Yes.
Assisted
correct.
suicide, there seems to be, I can't think of I didn't find any cases anyway where in the United States physician-assisted suicide was legal. Specifically, I'm sure it happens. I mean, I'm not naive enough to think that it doesn't happen in some way. But I might be completely wrong on that.
Physician-assisted suicide, yeah, it is legal in several states. Physician-assisted suicide, yeah, in California, Oregon, Washington. Oregon was the first state to legalize assisted suicide back in the 1990s, actually. And so we now have, I'm going to say it's maybe 7 or 9. I can't remember the exact count, but somewhere in that ballpark, there are a number of states that have legalized it, either and in different forms. So in some states, they've actually legalized it through legislature. In other states, it's become legal through, for example, a court decision, which has, basically made it so that even though there's not a law that says this is okay, there's a court precedent that suggests that if you do it, you're not going to be punished, or something along those lines.
Gotcha. And so by the end result is still the same. I mean, whether it's legislation from the bench or actual legislation. So there are countries, though, even to our north. I mean, I was born in Canada, and I've mentioned this on the show before that the MAID program in Canada is nationwide, and physician-assisted suicide is legal, and not only legal, but seems to be sort of recommended for quite a few people, not only at the end of their life, but I heard about a couple of stories about teenagers who are experiencing depression, and if they decide that it's time to go, then I can't wrap my mind around that. I can't. I don't know how we made that jump, philosophically, societally, from at least nominally Christian. I mean, Canada was British or it's French, either way you want to slice it. There's a lot of immigrants there now,
Yeah.
but for the most part, it was a Christian nation. The Church of England is still the official church, um, but nonetheless, it seems like there's quite a few European countries as well as Canada who have gone whole hog towards physician-assisted suicide, not only as acceptable but as a good. So how do we sort of? And it's. I guess I'll ask the question this way. A lot of people, especially in the United States, are so singularly focused on the issue of abortion, which the USCCB says is the preeminent issue. It is a scourge in our modern society. It's a modern day genocide. I don't want to devalue that. But euthanasia seems to be something that, or physician-assisted suicide specifically, seems to be something that's sort of creeping in a lot of ways. It doesn't get a lot of attention. It's not as big in the news as some of the other issues. But it seems to be something that could overtake us. And in Canada, this has profound effects on the way that the elderly especially are viewed. Right? People are viewed more as commodities rather than as persons, where they can just be discarded if their suffering is too great, or if the family doesn't want to deal with all of the issues surrounding the care that these folks need. So how do we, as normal, not people engaged in ethics on a national scale, or not people engaged in politics, but how does the average person push back against this? How do we change the culture, even in small ways?
Well, yeah, that's a great question. Because I think that in small ways, I mean, I'm thinking local level, parish level, family level. I think it's really important. You know, we begin to live out as best we can in our own families, in our own communities, the value and the dignity of human life. You know, we have to interact more with our elderly, support them, sustain them. We need to, show that we care about this and that this is important, because I mean, ultimately, in the end, this is a reflection of decades of cultural change. You know, where our whole society. I mean, we're essentially just beginning to reap the fruits of something that has been put in motion for quite a long time, that much of our culture has absorbed. So to actually get to a point where the legislative changes are happening, we've already had plenty of time where the culture has been regrettably overcome by this culture of death, as John Paul II has called it. So we need to rebuild that culture of life, which starts local, and that just means we support and sustain our local communities and show that dignity, that these people have dignity, that there are people who are willing to sustain them, because a lot of the reasons that lead to euthanasia and assisted suicide is this sense of a lack of meaning, lack of purpose. You know, what is my life for? You know, I'm an older person, or others who look at them and say, well, they can't do anything anymore, and so they have no value anymore. So it's a both and of the individual who experiences a sense that I have no value or meaning or dignity anymore, and those who look at the individual and say, well, they don't have any value or dignity anymore, because of their lack of ability to do things, or that they're, now takes a lot of time to take care of. But one thing I will say, this is happening, and so I would encourage others to do it. Like, it's actually a beautiful thing, though. We get so many calls asking us for help with how do we make good decisions at the end of life, and proportionality of treatment, ordinary, extraordinary means, etc. But so many of these people calling us are actually themselves living witnesses already of how much they care for example, their elderly parents. You know, the number of end of life calls we get is probably 30% of our consults deal with these kinds of situations. And I just continue to be inspired and uplifted by average chaplains in a parish who are calling us for help with decisions, but they're already like, yeah, I've been taking care of my mother for 15 years at home, and managing all of her care and doing all these things. And I'm like, wow, now that is how you change the culture. What you are doing, if more people will be doing this, And that's how you get witness that this person has value, has dignity. You're loving them, and you're giving them the sense that you care about them, and you're showing your community that this is something worth doing, to invest that time, to invest that energy, and to sustain those loved ones. So I would just, in that sense, a note of hope that, apart from, hey, how can we, this horrible situation, it's already happening and more people can do it. And maybe local parish communities can try to support and sustain those in that situation, and, bring together some of their younger parishioners to help with their older parishioners and things like this. Who knows? And that's, I think, the way forward from the cultural standpoint. If you're asking again for the average person who's not engaged with politics, who's not engaged with, the bigger picture, it's our own actions and choices that can begin to change this direction of the culture.
Well, and it's a beautiful testament to love, and a witness to that, to human dignity and to love. I know at the parish where I worked, we had this beautiful program. I can't remember the name of it, but there was these people that were trained to provide respite for caregivers, where they'd just come and sit with the person for an hour, 2 hours.
Yes.
So the caregiver can go and do whatever, watch a movie or go to the grocery store, or you name it. And it was very, very valuable, because this person wasn't a therapist. They weren't there to provide care. All they were was a parishioner, average parishioner, who was able to be present and show care to the caregiver.
Yes.
And so it's just this beautiful way that we all can help. We all can do something. And that's why I wanted something practical. And so I appreciate your answer there. Because the people who are engaged at the national level, or even at a local level legislatively, they know what's on the table. They know what's at stake. They know what they need to do. But for the vast majority of people, they're just sort of lost adrift, and they see this great evil and they go, how could I possibly fight against this? This is the whole culture seems to be opposed to Christ and the gospel. Like, what am I going to do? And I think your answer it has a lot of wisdom to it. It's just be a witness right where you are.
Yes.
Do what you can. Figure out what you can do. Figure out what you are willing to do, and then do it. Right.
Yes.
So it's not as hard as we make it sometimes.
That's right. And I would add, though, don't discount the political involvement for even the local average person.
Yeah.
I don't mean you have to lead the efforts. But when it comes time to vote, you should show up and, make sure your voice is heard. If the people who are doing that work of getting the ballot initiatives, or getting, whatever it is, like the good legislation, or trying to block the bad legislation, and if anything is coming up to the vote for the average citizen, it is important that you make your voice heard, because that is also a way everybody can contribute at that level. In addition to living it out, also when the choice comes up, make your voice heard at that time too, so that your local communities and political communities, again, from the local level up through the state and the national level, your voice does matter in that way as well.
Yeah, well said. And we have to be knowledgeable about all of those things. So it means being constantly engaged and learning, and then also sharing that with the people around you in your own way. So yeah, it is a holistic picture. Practically, so you mentioned some of those end of life calls that you get, the 30% of consultations you do. That was one of the biggest questions that came up when I was doing anything related to this at the parish level. Is, well, what is ordinary means? What is extraordinary means? And this has profound implications, because if we transgress some of these things, we are participating in the culture of death, whether we acknowledge it or not. So what is the general difference between ordinary and extraordinary means? I mean, obviously, there's so many different applications. There's so many different specific circumstances that people might find themselves in. But I guess what's the difference between ordinary and extraordinary means? And then, should people have a living will? And what sort of things ought to be in it? Now, obviously, we're not giving legal advice here. But at least what should, I guess I'll put it this way. If somebody wants to have a living will and they go to an attorney, what sort of things should they say to make sure they say, this needs to be in it? This is a non-negotiable for me.
Yeah. Excellent. Okay. So let's say this. Ordinary and extraordinary, first of all. I'll quickly point out that in that same 1980 document of the Congregation for the Doctrine of the Faith on euthanasia, they talked about this distinction of ordinary, extraordinary, and they actually proposed the use of terminology of proportionate and disproportionate as opposed to ordinary, extraordinary. Now, we're going to keep using ordinary, extraordinary, but I just want people to be aware that to get the concept, it can be helpful to use that terminology, which they said is actually a little bit more technically accurate, because what ordinary and extraordinary comes down to is simply a judgment of, does this treatment offer a reasonable hope of benefit without imposing excessive burdens? In shorthand, do the benefits outweigh the burdens? So that's the simple answer, right? And that means there's not a definitive list, which most people think there is, or wish there is, or ask for. Like, hey, what, I want my ordinary list and my extraordinary list, and is the ventilator on that extraordinary list? And what about dialysis? Is that one on which list is that on? There's no list. Sadly, on the one hand, because I can't give you an easy answer, but actually wonderfully, on the other hand, which is the actual church teaching, which is that it really just depends on your circumstances, and you, as the patient, are the one who has the prudential judgment to make about whether the benefits that this intervention offers you outweigh the burdens. Right here and now, in your particular circumstances, in your clinical picture, and your overall life circumstances, does, doing dialysis, continuing dialysis, or starting dialysis right here, right now with your whole situation, is that something that offers you a reasonable hope of benefit without imposing excessive burden? Is that something that offers greater benefit with respect to the burdens it entails? And the reassuring thing for many people when we talk about this is that, most people are thinking, well, the church requires us to keep, our life and to not do anything to kill ourselves. And we talked earlier about that, the euthanasia question, and, sometimes you might refuse a treatment and you're going to die as a result. And people are like, well, if I say no to the ventilator, or if I say no to dialysis, then I'm going to die. And is that okay? And again, it can be, yes, if the reason you're saying no to the dialysis, the reason you're saying no to the ventilator, the reason you're saying no to, even if it's antibiotics or whatever it is, if the reason you're saying no is because that particular treatment either doesn't offer much hope of benefit, or it imposes excessive burdens with respect to the benefits, then that's totally fine, even if your death may happen soon. So the church's teaching is not life at all costs. It's not that you have to go to all extreme means. In fact, the church has long taught that we all need to accept that. It's the end that comes to all of us. The key is simply that, as we said earlier on, and here's where that distinction comes back, you cannot directly intend or will your own death. But what you can directly intend or will is to say no to a burdensome treatment. I can directly say, hey, doc, that surgery you're saying, that heart surgery you're offering me, which has, a 30% chance of success, and which is likely to, leave me in a very difficult situation afterwards with a really long recovery and all sorts of potential complications that might follow from that, even if it is successful, I can directly say no to that. That's what my will can say no to. But when I do that, I'm not saying no to my own life. I'm saying no to the burdens of this intervention that's been proposed. And the same for stopping a treatment that's already started, because that's another common misconception people have. They're like, well, once I start that ventilator, if I go on the ventilator, or if I start with dialysis, then I'm stuck. I have to stay on it forever, and that's actually not true either. You can say, hey, right now, it seems that the benefits are pretty high and the burdens are pretty low, or at least the benefits outweigh those burdens. And so let's go for it. And you can revisit that in a week. You can revisit that in a month, and depending on which treatment it is, and say, well, how have things been going? Is it actually working out as well as we thought? And no, it's not. Well, benefits are lower than we expected now. Or, ooh, wow, this has been a lot more involving. It's been more expensive. It's been more costly. It's been more time consuming. It's been really difficult to manage it. It's been more painful than I imagined. Whatever that is, oh, those burdens have gone up with respect to your initial judgment. And now you can say, hey, what I originally thought was, up here's the benefits and here's the burdens. And so it was proportionate. Now it's like, whoops, wait a minute, a week later, a month later, not worth it anymore. And you can totally say, time to stop, time to withdraw this intervention. Yeah, we've been doing it, we've been trying it, we gave it a shot, it seemed like it worked, but it's totally fine to reassess. Again, prudential judgments are circumstance-based. And so here and now, it's not working, or it's not worth it from the benefits and burdens standpoint. And again, the key notion is you're not rejecting your own life when you say no to a treatment that's very burdensome. What you're rejecting is the burdens of treatment. You're rejecting burdens of treatment, not burdens of your own life or your own life itself.
How does basic needs like food and water enter into that?
Yeah, great question. And actually, there's a lot of debate and discussion about that in the past several decades to clarify it. So without giving that whole history, let's just say that the situation is the church teaches that basic human care is always morally obligatory. In other words, it should always be done. Basic human care means nourishing, hydrating, warmth, basic hygiene, these sorts of things that you would offer to any human being in any condition, to the best of your ability. So in principle, we should always provide nourishment and hydration, food and water, okay, in simple terms, which leads to a corollary that if the person is not able to take food orally by mouth, right, then we should, as a general rule, provide it by another means, as though IV or NG tube through the nose or PEG tube directly into the stomach or the intestine, whatever that particular means is that's available. The general rule is, hey, you should do that if the patient can't take food on their own. But there are a number of exceptions. Why? Because the means by which you're going to be delivering that nourishment and hydration are an intervention that can be assessed in terms of its burdens and risks and how likely it is to succeed, whether it causes complications, etc. And so the way I explain it to people is I say, look, hey, generally speaking, you should always nourish and hydrate the patient, even by medically assisted means, if they're not able to take food orally. But there are 3 exceptions. You don't have to put that feeding tube, or you can withdraw the feeding tube if, number 1, it's actually not nourishing or hydrating the patient. And that's just fairly obvious. If it's not achieving its finality, which is to nourish and hydrate, then you don't have to give it. Number 2, if it's causing serious harms, complications, or burdens associated with that means of delivery, which I was just saying. So it could be complications at the site of the tube insertion. It could be, in some cases where a patient becomes extremely difficult to access the veins, maybe even for some elderly patients. And that whole process of, can we find the vein and stick this thing in there? And, all of that can be part of a complication and burden. Or even when it comes to a very frequent scenario that we encounter, which is with any kind of neurodegenerative or mental health situation, like a dementia or an Alzheimer's, Parkinson's, when they get to a certain point where the patient is not really cognizant of what these things are, and they may be pulling a tube that's been either surgically inserted or it's an IV or whatever it is. And if they're at high risk of pulling tubes or they get really agitated with these tubes, if there's no way that we can simply and easily kind of keep that under wraps, like sometimes it may be as simple as just covering it so they don't see it. Well, if you could do that, do that. But if that's not sufficient and they're just still at high risk of ripping these things out, causing harm, that can be another reason, a complication or a burden or a difficulty with the actual delivery itself by the medically assisted means can be a reason to say, all right, we can withdraw it or we can, decline it. And then finally, the last exception is if death is imminent. And that one we very rarely encounter in actual consultation because imminent death basically means you're sure that because of some underlying pathology like a super aggressive cancer and the doctors are essentially sure you're going to be dead in the next day or two. Okay, at that point, the continued provision of nutrition and hydration or trying to insert a feeding tube at that point, you certainly don't need to do that because it's not going to have any real impact on the timing of death or in the causes of death at that point. And so that can be another situation. But as I said, that's very rare. The most common reason is actually the complications, burdens, and risks of the tube, and things like, it could even be an aspiration pneumonia. The person is at high risk of aspiration, which can happen as a result of the delivery of the nutrition and hydration. It's just too much fluid for the body to handle, and everything is gone on. And, maybe they've had a few instances of aspiration and pneumonia already that they've tried to treat and said, all right, well, this provision of nutrition and hydration is now actually contributing to that, which is likely to just keep happening. It's happening frequently. We don't have to keep insisting on it at this point. So,
because at least anecdotally, both my parents are nurses and my wife's a nurse practitioner. And I mean, they've told me plenty of stories that there's people who in the last days of their lives will, even if they don't need a NG tube or anything like that to eat, will just refuse food. Generally, people just sort of get to this point where they no longer have the desire to eat. And it's usually a pretty good indication that death is imminent. So certainly in that case, I would say anyone who's caring for their loved one, don't try to force them. Because I think and you're alluding to this, there's a lot of people who think it's about life at all costs. We need to do everything possible to keep this person alive. And so what you're proposing is, and what the church has proposed, is this proportionality, right? And saying, what do the benefits outweigh the burdens, which does change. I mean, that's something that, I mean, you mentioned that there's not like a list of proportionate versus disproportionate things. And that makes sense because even medical interventions have changed considerably in the last decades.
Sure.
You mentioned dialysis. I mean, my mother currently works at a dialysis clinic, and my dad did as well before he retired. And they were telling me about this, because dialysis, for those who are listening, you have to go and you get this treatment a few times a week, usually, where you're sitting in a chair and they hook you up to a machine and it cleans your blood, basically. It functions as your kidneys. And there's a new way of doing it where you get this surgically implanted device and you can do dialysis at home. You can do it on the go, which is amazing. I mean, that's a tremendously different process than someone who's going to a clinic. And it's just one example of, there are so many different interventions that have changed considerably in whether or not you could call them burdensome.
Yes.
Or
how much of a burden. Yeah.
Right. And so that fundamentally changes how we would evaluate these things.
Correct.
So there's a lot of really good distinctions in there. So I appreciate that. That's why I asked you on, because this is way out of my wheelhouse. But it's good to know that not only there are answers, there are principles, but that there's somewhere people can go to ask these questions, which is it's such a blessing.
Yes. And we'll walk people through the particular case too. That we don't make decisions for you, right? But we'll walk you through all the distinctions as you explain to us the situation and say, hey, this is what's going on. This is what they're saying about me. It's the 52, or it's, my mother, or whatever it is. And we'll say, okay, well, here's what you need to think about. Yes, you're already on the right track. Because a lot of times people say, well, this is what I'm thinking. I just want to make sure I'm understanding correctly. Or we'll say, well, yes, but there are a few distinctions you missed, and let me explain what those are, because you're really going to need those to make a good informed decision and a sound conscious judgment here. And actually, on that note, I'll make one more distinction, just to clarify with the nutrition hydration question as we kind of wrap up. I do try to emphasize that nutrition and hydration assessments are not just the same as any proportionality assessment. Because there's a risk, there is a default position, we could say, in favor of the nutrition and hydration. So we should always be assuming that we should provide it, unless there's a clear reason we should not. Whereas with any other intervention, surgeries or dialysis or whatever, there's never like, oh, we should just presume yes unless. It's, well, let's just consider it. Hey, is this, ordinary, extraordinary in this circumstance? Like dialysis, you wouldn't say, oh yeah, we should assume it's okay and just only not do it if there's a reason against it. No, let's just start with, we don't know. Is it okay? And let's look at the benefits and burdens. And if we say yes, then yes. And if we say no, then no. But that's the difference. So nutrition hydration is sort of assumed that it should be given because it's basic human care, unless there's some clear reason against it, whereas everything else is just sort of assessed on its own right. And one of the biggest mistakes with nutrition and hydration is when people are saying, this most common situation of like, well, what are the complications, risks, burdens, harms of providing nutrition and hydration? Many times they'll look at it in terms of, well, providing nutrition and hydration is not worth it because the patient's not going to recover from Parkinson's. Or they're going to say, well, the patient's going to die anyway in 3 weeks, from cancer. And so the nutrition and hydration is really not that helpful because they're going to die anyway. That's an incorrect assessment because we're not supposed to be assessing whether nutrition and hydration is going to heal or cure any medical condition. It's never expected to do that. It's not what its finality is. The finality of the nutrition and hydration is to nourish and hydrate. So we can't say, well, because the nutrition and hydration won't heal the cancer or it won't, bring back this person from their, mental health condition. Okay, therefore, there's not a reasonable hope of benefit. No, the benefit is in, is it going to do what it's supposed to do? Is it going to nourish and hydrate? And if it is going to nourish and hydrate, and then yes, there certainly is expectation of benefit there. The question is simply, what will the cost, burden, or risk be? Not whether it's going to be beneficial. So just wanted to make that clarification as well.
No, I appreciate that. Well, and my immediate response to anybody who says that is, all right, buddy, you go without food for 3 weeks and see how you feel. Yeah, no, I think there's some level of common sense there, I would hope. But in the middle of these decisions, people can be very confused and not sure what to do and be overthinking everything. So I definitely understand that.
Well, and they're getting input from medical staff too, which in some cases, particularly if it's a secular mentality that they're receiving through their healthcare team, it is going to take this approach. And many times that's what they're hearing is that, well, they're going to die anyway. So it's really not going to be very helpful. And so in some sense, they're often reiterating things they've been told by the healthcare team, which we have to help them, parse through. It's like, okay, well, let's clarify with the medical team what they mean by that, though, and see how that works in a proper framework of understanding, is it nourishing and hydrating versus is it going to, heal your cancer?
Perfect. Well, a lot of good practical distinctions here. I really appreciate it, John, and thanks for coming on. And once more, if you would just tell everyone where they can go if they have a question, if they need a consultation. What's the website and what's the phone number?
So the website is www.ncbcenter.org, National Catholic Bioethics Center. And under personal consultations, they'll find a link for free ethics consult. There's also a button right on the front page that says, we're here to help, request a free consultation. The phone number is 215-877-2660.
Fantastic. Well, Dr. John DiCamillo, thank you so much for coming on, and thank you for your time. Thank you for this conversation. I really appreciate it.
You're very welcome. Well, thanks for having me on. I appreciate that.
Thank you. And for all those listening, please go to National Catholic Bioethics Center. Not just if you need a consult, there's a lot of great stuff that's put out by the center and a lot of good information on the website. So definitely highly recommend checking that out. Also go to gooddistinctions.com and become a free or paid subscriber to support this channel. And like us on Instagram and YouTube and wherever else you can find it. Leave a rating on Apple Podcasts or Spotify if you're listening there. And I think that's enough of that. So, John, thanks so much.
My pleasure. Well.
And we'll see you next week, everyone. God bless.